But I go through and I test her reflexes. So I test her biceps and triceps, brachioradialis. I'll do that. You have some jumpy ones.
I was going to say, when I was young, I always thought, wow, I'm really healthy. Man, my reflexes, this is super.
Right. So I'll go ahead and demonstrate that piece. So do you guys remember for the patella reflex, spinal levels?
L5, 6, 7, 4, 5, 6.
So the knee is between L2 and L4, right? And then the Achilles is L5, S1, right? Those were the two we went through. That's fine. Okay, ready? Woohoo! How's that look? Now notice where the reflex goes. Are we looking at just a single joint? Or where does it travel to? All right, so here's somebody who's hyper-reflexic. Right? So in the grading system, 2+ was a normal reflex, 1+ was diminished, 0 was absent, 3+ was hyperreflexive. Hello. And then 4 was clonus, so that's when the reflex starts and then it cannot be stopped, right? So what number would you give her? 3, right? And then with the, I don't know if you guys can see this,
Yeah.
right? And of course you do, you got a good one. Can I have you lay down?
Sure.
This end, so they can see your feet.
And as an assistant, I'm asked to check reflexes very often, so kind of put that
Can I
away
take off your
to
shoes?
Sure.
real practice.
You check them often?
Yeah.
Yeah.
PTs will say, please check your reflexes next time and document them.
Yeah. I don't know if you can see the clonus in her foot. Kind of watch closely. You see the bump, 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 bump. Okay.
Because I'll see that.
Yeah.
Yeah.
So with clonus, you can come closer. She won't mind. If you need to see, or when we take breaks, we can come up and have a look at it again. But so with clonus, when you document clonus, you either document the number of beats that you visualize before it stops, or in cases where it takes a long time, sometimes you'll mark time. So she's got about 8 or 9. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Well, it keeps going. Because now her nervous system is a little bit more anxious, right? Because she's being watched. You see how it continues to go. So folks with a spinal cord injury or a brain injury, when there's something systemic going on, let's say they've got a urinary tract infection, or maybe their shunt's infected, or maybe they've got some gut dysfunction and now there's an active infection, you can often pick up on it by seeing a change in reflex activity. Right? If you see clonus increase all of a sudden, and you see someone that can't inhibit it, and then they're also showing other signs, maybe they're a little bit more confused, a little bit less responsive, that would be a call in to the physical therapist right away, or your medical personnel to have them be reassessed, because there may be something systemic going on that nobody's picked up yet. Okay. I'm going to leave you down here. So reflexes, there's the deep tendon reflexes, right, upper and lower. Are you jumpy up top too? See, now that's the casual language. I can speak to her like that because I've danced with you at your birthday party. So there's normal deep tendon reflexes, where you're really looking at that reflex arc and whether or not they can get the input and how the nervous system regulates the input. And then there are abnormal reflexes, and Mark will be going into these in his class. But there's abnormal reflexes that you don't expect to see in someone who doesn't have an upper motor neuron dysfunction problem. Okay, and one of the big ones is, there's two. You look for an exaggerated plantar support, positive support, so you can simply take your finger and put it underneath the toes. And if you ever have done that with a baby, where you put your finger in the baby will grab it, okay, that's a primitive reflex. And it gets extinguished over time as the child develops. With a brain injury or neurological insult, sometimes those can come back. So you can put your finger right in here, and sometimes the toes will curl around your finger. And then the big one is called the Babinski reflex, and that's where you take your thumb and you drag it from the heel around the lateral aspect of the foot and across the toes. Right? And what you're looking for, if it's positive, is toe splaying, so great toe extension and toe splaying. If you have a brand new baby, it works on them. I did do it on a brand new baby in an elevator once without asking. it was really embarrassing. I don't know why I did it. I was in PT school, and I was coming down from the anatomy lab, and we had just learned about it, and this woman was holding her baby who had no socks on. I just went up and did it. I wanted to see it. She looked at me like, "Why are you touching my baby?" And I apologized, and she laughed at me because she was okay with it. But yeah, don't do that. So you just kind of come up in here, give it a quick. I don't know if you can see it. You can see what I'm doing here? Yeah. And so this would be negative for her, right? She doesn't have that. Again, if you see that in your patient, that's a sign of some significant upper motor neuron dysfunction. If she didn't have it before and you read negative in my evaluation and you see it again, that's a change in condition. That's something you want to talk to the physical therapist about. All right,
And you
so
guys can see that next week in lecture.
right,
Yeah.
good. So I've checked her reflexes, and I kind of have a better idea about what her system processes in terms of sensory input on a pretty basic level, right? And none of the things that I did really requires her active participation. So once I can get her, actually, can you let this one down? It's doing its thing.
Yep.
Isn't that fun? Well, let's just go right into the. So she's not able to relax her leg.
Because I was going to ask you, geez, one end higher than the other.
You're stronger than gravity right now. So I'm just going to block your face for a minute. Just going to see. No, I can't.
You want a triangle or anything?
You know, I think a wedge would be better.
Yeah.
Yeah, let's do that. So now I'm going to check tone. And this is something that we'll be practicing in lab. Who can give me kind of an idea of what they think of when they hear the word tone? Tone. It's on your neuroterminology sheet, too.
Of course we studied this.
No, you don't. No, we had it before. There's no test. Just ideas, really. Let's try this.
Okay, do I get to ask questions too?
Yeah, absolutely.
Okay, because it seemed like now when you took your hand and just rubbed that a little bit,
Uh-huh.
it did relax.
It helped, didn't it?
Yeah, so,
Yeah.
Better? Comfortable?
Yeah.
Okay, good.
but it does. It's still-
Yeah. So Karen was noticing that when I put my hand on there, and I was using a tone inhibition technique to get it to relax. She goes, "It seems when you did that, it felt a little bit better." And then I stopped to do a positioning wedge, but we'll talk about that. So tone is just kind of the resting activity of a muscle, right? And you get some information about responsiveness and readiness to move by assessing tone. And it's done completely with your hands, right? It's done completely with your hands. This is really the hands-on stuff. And it's relatively subjective. There are some measures like the modified Ashworth scale that you can use to document tone. Some places will use that scale. Other places will use the more subjective, hypo, flaccid, hypo, normal, hyper, spastic. So that's kind of the continuum there. So I'm going to get an idea of her tone. And I'm going to do that by making sure I have, drop my papers on the floor. I'm going to climb up here with you. Yay! And so, you're really kind of getting a sense of the limb by proximally and distally. And so this is where your manual contact is really important. We talked about the lumbrical grip. You notice I'm not squeezing. And with tone assessment, you really are kind of cradling the limb a little bit and gently touching the lateral aspects of the limb so that if something were overreactive, by the touch, you're not stimulating more tone or inhibiting tone, conversely. So you're really kind of grabbing around the lateral aspect. And you're just kind of moving it slowly, right? And I like to start in a mid-range just to get a sense of what's happening with the arm. And you're going to do each joint. You're going to take each joint through its range and get a sense of, is there passive resistance to stretch? Right? Do you feel passive resistance to stretch? And then what does the limb feel like in response to, when you take the weight of the limb, how does she respond to that? Does it feel floppy, like there isn't a lot of responsiveness in it? As you move it around, is there a little bit of resting tension in there? Okay. We'll look at the elbow. I'm going to take it through its range. Remember, kind of the difference between tone and spasticity defined is the velocity of the movement. So if I want to take a look to see if there's a spasticity component, I'm going to move it faster to see if I can feel if it's rigid, cogwheel rigidity, or spastic in one direction, or spastic